Welcome to the For Health's Sake podcast, brought to you by Edito Health, elevating digital transformation with a human touch. This episode is sponsored by Radical Health Festival. It's critical to be radical.
Hello and welcome to the latest edition of For Health's Sake. I'm Charles Alessi, and today we're going to deal with one of the most thorny issues, paradoxically, that exist still within the health data space, and that is interoperability. We've long been thinking and talking about interoperability for more years than I'd care to remember, and to a degree, it's sad we're still talking about it because we should have fixed this. But to help me understand why we haven't quite fixed it, I'm delighted to be having a conversation with Alexander Berler, who's the Director for Strategic Business Development at IHE Catalyst. And welcome, Alexander. And could you help us a little to start with by giving a sense of what IHE Catalyst is and what it does?
Thank you very much, Charles, for this opportunity to talk about interoperability. We usually talk a lot. Unfortunately, we talk into small groups, and maybe that's one of the topics and the problems that we face, that it's not a universal discussion. So we'll come back to that, I guess, later on. Now, what IHE Catalyst does. So let's start by just saying a few things about IHE in general. So IHE is an acronym that stands for Integrating the Healthcare Enterprise. And it started at the end of the last century, so 1998, in a way of trying to solve an equation at that time, mostly intra-hospital, so not about...
God, you make me feel so old, at the end of the last century. But you're right, it is at the end of the last century, yes.
We are a little bit relics, so, you know, I also feel very old sometimes. But the idea, you know, the interoperability was dealt by two major communities, which is the users and the vendors. So you can try to map this. The users are the ones that create the demand, and the vendors are those that create the supply. So the scope of IHE, when it was initially created, was a very basic engineering idea to try to solve the interoperability equation by bringing those two groups together, which was not the case before. So each one were talking to each other, but they were not talking to each other.
Yeah.
So in that sense, and try to reuse methodologies that were not used at that time in the healthcare sector, about profiling and especially introducing the concept of testing. So anything that you use from a simple pen to a helicopter or to a rocket is being constantly tested before it's put into production. And that was a parameter that was missing from the healthcare domain. We had a lot of standards. We still have a lot of standards. But the concept of IHE was to orchestrate how those standards should work on a use case approach. So, and this is where we bring the users and the vendors closer. The users are coming and they say, I have this problem. I want to share my medical images from one doctor to the other. How do I do that? So that's a business use case. And then the vendors and the users, both in reality, they come together and say, in order to make that use case a reality, we need a couple of standards. So we need DICOM for the images, we need HL7 for the documents, we need some W3C standards for the security parts and the exchange. So we need to have secure channels for all this. So the concept of IHE is that we create what we call technical frameworks and integration profiles that can be tested. So we orchestrate the standards in a way that they can be implemented in real life. And so that was the initial concept. We started only in the radiology domain, and now we have 12 domains and about 380 profiles. Not all of them are used in practice, but about 70 of them are adopted by the market and the vendors. The second thing that IHE does a lot is what we call testing events. So the testing events in the IHE ecosystems is called Connectathons, which is the acronym for connectivity marathons. So what we do is we bring all the vendors that want to test a specific set of IHE profiles, meaning this orchestration of standards in a way that can be tested, in the same room for 1 week, and we ask them to test the different actors, because when we want to exchange information, someone is creating something, someone is consuming it, for example, trying to speak as simple as possible on those terms. And they have to test between themselves so that a specific use case is tested. And then they get what they are able to issue an integration statement that for this specific profile, which is a combination of actors and transaction, technically speaking, they are capable of exchanging a set of information, whatever that is. So this term of testing has moved a lot since then. Now we have a huge amount of testing, which organized in testing strategies and testing continuum, but probably we can go in more details about that in the future. So in that ecosystem, there is IHE International that creates those technical frameworks, and all the members, users and vendors are contributing to the technical committees that are doing that. And then you have local deployment committees, which are created by region. Usually it's a country-based set like IHE USA or IHE UK or things like that try to bring this closer to a specific market. And the role there is to educate and streamline this on the local markets and potentially with the local vendors. Now, in that context, we saw that in order to make that happen, we needed somehow to streamline all these processes. And this is why 3 years, in May 2025, IHE USA and IHE Europe, which is a group of 11 deployment committees in Europe, said that we need an entity that could act as a project office so that we could combine forces and build one set of tools that anybody uses.
Yeah.
And try to co-share the experience in organizing the testing events so that we can create pathways also for the users and the vendors. So the users, they want to bring new use cases that they want to create and they need to be tested. And the vendors, they need to align their product lines of products and prototypes so that they know what to put in the market and when. So this is a complex combination of real life and standardization that IHE tries to solve. And IHE Catalyst, that has been created especially for that. So IHE Catalyst is the project office of the IHE ecosystem, and it serves both the user, and users, we can have hospitals, we can have primary care settings, patient and doctor associations, but also governments and global institutions.
This is really interesting because in many respects, we tend to forget how difficult and complex this area is, because we know that culture eats strategy for breakfast. I mean, that happens all over the world, and we're dealing with an awful lot of cultures here. But as well as that country-specific issue, we're also dealing with the fact that we have very different health systems. So in Europe, we have a social medical type model, be it, different types, but that is the basic premise. In the US, it's more on a commodity type approach where one uses healthcare in that dimension. And the tools and necessities and requirements for interoperability are fundamentally different in both of those systems. And if we actually push the envelope a little bit more and look at the preventative agenda, for example, in Europe, we're really keen on combining health and social care and, managing the non-health determinants in a certain way because they're part of our social medical approach. And in other countries, that isn't necessarily as important because they don't have that element that lies within that brand of health and care that is produced in that country. That must give you enormous problems in terms of standardization.
So that's why the concept, there are different terms that we need probably to explain to try to see how we should, and we are working in that complex domain. So one thing is that you frame the IHE profiles based on very specific use case. So e-prescription, medical imaging sharing,
That's common.
Summary.
Yeah, those are common.
You create a box of Lego.
Yeah.
And you put the Lego components in the box, and then you let the project owners, those can be a government, a company, a region, who else? Like the European Commission, for example, that is a conglomerate of different countries.
Yeah.
To take out of the box the Legos that they want to reuse, and then you can assemble them, and then you can create new pathways based on that. So this is the interesting thing in this. And the good thing is with this approach is that we can add a new term that we have added in the last, let's say, 10 years, which maybe it's a European invention. It's one of the very few European inventions that we have managed as Europeans to do, is the concept. Yeah, the other one I know is GSM. I don't know any other. All the others, they come from USA and Asia, unfortunately. So yeah, we're talking too much and doing less. But coming back to our topic, it's a term of projectathons. And this was initiated by a very big European project called EPSOS that tried to create some initial European highways for cross-border healthcare. And the idea there was to try to find ways, having 27 different healthcare systems, so you can understand the complexity, to build those highways based on this Lego box. So, and at the end, they assembled a way, and now in those projectathons, we are doing end-to-end testing, which means that you can test the different actors and transactions, which means different systems and software components, how they interact end-to-end until this use case has been achieved. So this is how we address this complexity. And strangely enough, at the end, the 80-20 rule still applies here, which means that at the end of the day, about everybody is using at 80% the same parts of Lego when they are building their use cases. So it seems that it's very different, but at the end, it's not so different. Right.
Yeah, I understand. And I mean, we started with e-prescription, didn't we? And I mean, we have some examples of that cross-border cooperation. The things that come to mind, obviously, are Finland and Estonia and now Luxembourg, but probably it's more than that now. Is it more than that, or is that still the example everyone talks about?
Well, there are two use cases in Europe that have been implemented and they are into production with low numbers, because the cross-border use case, we are a common group of people, but not exactly. So we have a lot of things to do. And the reason it's not working so much is not on the technical issues. So the technical have been solved.
We're going to come back to that, Alexander. We're going to come back to that because that's something I want to press on. And this is an appropriate time. Let's talk about something which I think is really taking up a lot of column inches and a lot of heat and light at the moment, quite rightly. The European health data space. I mean, we've just ended in a situation where at last we seem to have an agreement. Now, quite what that means is another matter, but I think we've made progress here. I mean, what's your sense?
Yeah, we did make a lot of progress, and this was, I think, influenced by two political points. The first one was that they needed somehow to push this cross-border collaboration. And as you know, healthcare is out of the of the EU. It's a national thing. So the only way to push this for some type of common services is the equity and equality of European citizens wherever they are. So that was one topic. The second topic, which was really push things move much, much faster, is the COVID pandemic. So we saw during the COVID pandemic that we didn't have any data. We could not exchange even a COVID certificate between ourselves. So this came as a result because, you know, this was published as a proposal in May 22nd, I think, 2022, if I'm correct. And it took us 2 years of discussions until we managed to have a first vote on April 24th. So we have still a long way for that. But the data space, I think, has several components that probably we need to at least mention once. So the first one is that they want to make the cross-border services mandatory, which is not the case. That's why we only have 12 countries active out of 27, which means that a lot of countries now will be pressured to make internal changes so that they can promote cross-border and not find ways and
not find reasons why they can't do. Yeah,
exactly. So because it's easier to say I can do it than find ways to do it. So that's one thing. The second thing is that we want to somehow push what the Commission is talking about, the digital European single market, which also needs to be somehow in healthcare. And for that, we need to find a way to somehow organize that market, that people could sell products here and there, because this is not the case. At least in digital healthcare, the market is super fragmented. And this is why most of the European countries are in a decay mode, let's say, and they are all constantly being rebought by bigger companies, which are usually not European ones. So if we continue this way, there won't be a single European company in that domain, because it will be not rentable.
Yeah, and healthcare, of course, is one of the biggest and most prominent parts that of companies that actually contribute to gross domestic product within a nation. Yeah, and actually devolving that completely is crazy, especially for a continent like Europe.
Exactly, and for the moment it's a very fragmented market. We have 5-6 companies in each country. So if you add it, it's about 80 companies, 100 maybe, which is 1/10 of the USA market.
Yeah.
Okay, so it's really small if you compare it in sizes, and we are a bigger continent than the USA market. So it's a paradox. Right, so the idea was to find a way to change that, and this is under this concept of the European Electronic Healthcare Record Exchange format, which is a concept that was introduced in 2019, so just before the pandemic, as a need to structure commonly some clinical content into some type of clinical documents. And patient summary and e-prescription was the two first that we were piloted.
Yeah, I mean, everyone starts there because they are, in many respects, the easiest, the bottom of the Lego.
Exactly. Yeah. And now we are moving towards lab reports, medical imaging and their reports, and the discharge letters, and some types of extensions for rare diseases as well. So now we have increased the playground, and the idea is to be able to find a way to certify or self-assess the concepts we will see, so that vendors could sell their products in more than one country, and so increase the market size and the competition.
Yeah.
The other thing is the topic of secondary use of data, because there is a huge need, and this comes from the pandemic, that we need to find a way to rapidly be able to create new medication, new vaccines. We saw that. Yeah. And maybe new treatment plans. So there are a huge amount of rare diseases there that are uncurable because it's too expensive to find a cure. So, and doing research, you need structured data, which we don't have. So through the exchange format and other topics, the idea that will take obviously a long time, so we are not very far away from that, but at least we started to be able to create at a pan-European level data that will be either named or anonymized, that could be used for such type of secondary use of research and innovation.
We have some examples in Europe, though, which are probably some of the best in the world. And I mean, PIN data is, the example. I mean, I always push back against us using the word secondary use because it's so old-fashioned. The thought of us only using data for one thing, I mean, now it's pervasive. It's everything. It interferes with absolutely everything we do in our lives. So I think we've moved on from that. But it would be worth just reflecting a little on what the blocking has been, what the blocking agents are in terms of actually managing this process of interoperability. Because as far as I'm aware, I'm not a technologist. There is no technological barrier that hasn't been overcome. But we seem to be in a situation where the varying interpretation of rules around privacy, which are wholly appropriate, by the way, the rules, but their interpretation is somewhat mixed and somewhat varied. where the balance of risk and reward is very different or interpreted very different in different countries. I don't think we're ever going to solve this completely, but perhaps we can actually change the worst and make it closer to the mean, because we have examples whereby no data is being shared because theoretically there could be a risk of something being inappropriately used.
Yeah, you are totally right, and especially the patient consent and the patient rights sections of the regulation were those that were discussed the most, and for different reasons, we almost didn't manage to have a consensus because of that. At the end, they managed to get the consensus between the member states and the Commission. Thank God for all of us, because now we have lots of things to work. Now, I think that the problem is not technology. We have technology and we have standards, and now the different standardization organizations, the ASDOs, as we call them in short, they are collaborating much better than before. They start understanding that they need to work together, which means that, like, together between, let's say, IHE and HL7, for example, there is a process that now we can bring specifications to a testable format in less than 1 year, which was not the case before. So things are moving much faster. The issues that we face, that we have a lot of work to do, is on one hand the semantics. So we need to harmonize a little bit, at least a common data set about how do we handle some parts. And I think this will be a roadmap. So we will start with a small circle, then will become a bigger circle, and at the end, it will take, it's a path. But starting with the patient summary and the cross borders, we already have the first circle in place. So that's not too bad. The second thing is the organizational issue. So a lot of countries are organized differently. Some have metropolitan areas, like in the Nordic countries, so the cities are managing healthcare. In other countries, it's regional, and in other countries, totally central. Or national. So you have to find ways to organize that, and this is local legislation. So you cannot push for a common approach there. It's almost impossible. And this will still be a barrier for many cases. You have the example of Luxembourg, that it took them 2 years to pass the patient summary because it had to change the legislation. It was not a technical issue. So things
it
like
very
that,
rarely is a technical issue now. It's mainly legislation and mainly politics. I mean, Europe is a very federal, regional continent. And each little bit, I mean, go to Switzerland and you cross the road and you're in a different area, a completely different system. Germany is not very different either. So it's every one of these has to agree in their own right because they have jurisdiction.
So through the implementation acts of the regulation, at least the other two parts of interoperability, because if you see the concept of interoperability frameworks, the European Union has one, which we use for the cross-border approach, has these 4 basic layers. And this is not only for healthcare. It's a general, it has the technological one, which is the easiest. You have the semantic one. So what do we exchange in what format that is acceptable and commonly understandable? Then you have the organizational, who is doing that and for what reason and which power. And the last one is the legal. So you need a legal coverage. So there is a regulation, and it usually takes a lot of time, and it's highly political, which means that you change the government and things might take 2 years delay just for that. And it's in all countries the same. Okay, it's not something that specific country is better than others. So we hope, we are not sure, but we hope that the regulation and through this implementation act will somehow make things work faster in the first 2 domains, meaning the legal and the organizational one, by proposing specific implementation acts that will need to be adopted by the member states. Each one of them will adopt in a different way, like all the time. But normally, and these things works, probably the first implementation acts will be ready to be distributed at the end of 2025, so more or less in 1.5 years from now. So that's the fastest that we can go, unfortunately. So we hope that a lot of those things will be a little bit harmonized, and the idea is to make more use cases of interoperability work. And I think the only thing that will work is if we split this into specific use cases like we do in interoperability in general. So we just make the Lego box bigger.
Yes, I mean, there's no option. You're going to have to make it bigger. I mean, because, of course, as we develop the preventative agenda, of course, which is alive and well in Europe, certainly discussion about it, we're going to have to include elements of social care within this playpen. Now, that is a big issue because, of course, we don't even have the ontology we've agreed upon there yet.
Exactly. And it's not only about that, it's also about, it's the carrot and the stick. You mean you need to create also a market about a few things.
Yeah.
So you might create the perfect solution and the perfect use case, but if there is no demand about it, or there's no way of enforcing it, it's not going to happen. So the vendors, they're not going to spend and invest in creating new software that they cannot sell.
Yeah, but there is some pretty good practice in Europe at the moment. It's not all negative. We've got some good there's some good practice. So where have you seen some really good practice?
So as always, it's a map of things that are moving in parallel. Sometimes they are related, sometimes they are not. So there are several countries, especially the smaller ones, that are able to move much faster.
Surprise.
Yeah. And we see that the best practices in Europe are usually from small countries like Estonia in the past.
Yeah.
Right. Because they move faster. And usually those countries, they use at the political level, the European story to change things locally because they want to get closer to Europe for some reason.
Yeah.
And at the other hand, they have to do that because they don't have enough internal funds to make the change the change that are needed. So they need the European funds to do that. So by definition, they are forced to go the European way. This is usually not the case in big countries like France, UK in the past, where they were in the European Union, Germany, Spain, Italy, even. So they have their own roadmap. And in those countries, usually healthcare is regional, which means that what Munich is doing, Hamburg is not obliged to follow.
Yes.
Exactly.
And we actually felt this in the pandemic, of course, because the pandemic was the time when regional healthcare needed to actually become bigger because viruses do not understand borders. They go across them. And we had the issues we all understand because of that.
So there are some good examples of people that have organized themselves to try to advance the equation as much as possible. And let me mention a few of those and of different sizes so that we don't try to promote any of the specific groups.
Yeah.
So a good best practice, but which is ongoing. So I'm not sure if it's going to end well, but we hope it's going to end well. It's the case of my home country, Greece, where they created and piloted the creation of the national e-health interoperability framework as an extension of the European one. So their idea was not to reinvent the wheel, but reuse things that we can bring and customize to our needs without having to reinvent everything.
Yeah.
So they have the framework and they use that framework to fund, because the pandemic brought another asset, which was the RRF funds, so the resilience and restructuring funds, and which was about creating the big transformations. And you know that the digital one was one of the 4 axes of the RRF.
Yes.
So it was easy to get money for making such transformation. And through that, they managed to get the funds for different programs and projects, which if you add all of them, it's €500 million for digital transformation in healthcare. For a size of Greece, which is 10 million people, it's a huge amount. They would never.
Yeah, I mean, it's only twice the size of Finland. You know, it's not that big at all.
Exactly. So now they have a €500 million program that started last year and will end in 2026 about building all these new highways based on the European standards. So that's a best practice of potentially how you could find a way to push organizing the country the European way. So that's one thing. Another best practice, which is not so well aligned with what happens in Europe is the Ségur program in France, which is a 2 billion euros interoperability framework, which is, I think, not funded by the European Commission, or it could potentially partially be funded. And they have their basic idea is to try to renovate their electronic healthcare records program, which was in decay. It had 10 years ago less than 1 million records out of 60 million citizens. So it was a disaster.
Yeah.
The problem was not technology, so that the doctors were not pushing anything into it. Now, so they created that, they split this into 13 or 14 different use cases. And those use cases were designed by the end users, so the doctor association, the patient association, and all these things. And after this period, and they are funding both the providers and the vendors. So in order for people to adopt those French specifications, and you can get some funding. So there is the carrot. If you go this way, we will give to the hospital an amount. We will give to the supplier an amount to change his software. And this is how they are creating their program. There is no big project in France. There is no pharaonic project like in other countries. Everything is decentralized. And they have created a huge marketplace where 385 vendors, companies, are participating, and each one in their own specific domain, which for me is a good best practice for organizing big countries like France, Germany, in a very, very democratic way, pushing for competition, but with common rules. Now, France has not gone the European way, which means that they have to adjust their French specifications to what the European health data space will bring. But that's a one-to-one issue, so I guess.
But it's progress from where they were before, and I think you're right to bring these to our notice, because we are seeing some examples of good practice, and in many respects, this is exactly what we're hoping to be able to discuss in Helsinki when we meet very soon now. Because what topics are you engaged in when you're in Helsinki?
So in Helsinki, we are, as a partner of the events, IHE Catalyst is a partner of the events and supporting the events, as we do with all the events, as much as we can financially support, of course. Try to promote the interoperability track of so we have one presentation on that. And in our presentation there, we'll try to focus on how the testing continuum can be a catalyst for moving faster on one hand. And second, which is the most important, it's not the technological part, it's this ecosystem effect that the testing event brings. Because you bring the users and the vendors on the same place in an, let's say, environment where it's not a hostile environment for any of them.
It's neutral.
It's neutral, and then they can solve a lot of issues. And when you talk to those people, when they are in such events, they say that I managed to solve problems in 1 week that normally would have taken me 6 months or more to solve them myself. So
well, that's a wonderful note and a wonderful statement, because actually that's exactly what we hope to achieve at the Radical Health Festival, which is to bring people together, including clinicians and technologists and strategists, to really discuss the issues which in the past they've all been discussing, but within their own tribes, because I think we need some neutral spaces, especially when we're dealing with these difficult issues.
Yeah, and those testing interoperability labs that can also be online. Doesn't mean that you have to meet face-to-face, but face-to-face is more effective. It's this people, because at the end you need to have the human interoperability. We need not to forget that. So, and my vision would be to see if we could, in one of the future Radical Health events, have a parallel session where we have a testing floor in parallel for this type of community. It could be local, it could be the Nordics, it could be supporting mechanisms for the European Health Data Space implementation. It could be many things. So, and the second thing that we're going to do at Radical Health is trying to bring different initiatives about modeling of data in healthcare. And we have a session on Tuesday, the 21st, which it's a collaboration of IHE Catalyst and HL7 Finland, So it's trying to work together to try to bring on the same table different experts that are working in domains like IHE, of course, HL7 fire mostly, but also since we want to focus on the European Health Data Space, we are going to talk also about OMOP and about OpenEHR.
Yeah.
And see how all those group of people could work together in trying to solve this equation. And as IHE for us and IHE Catalyst, it's pretty easy to bring new use cases and create new integration profiles that will include OMOP and OpenEHR as well, even if they are not considered as standards for the moment. They are initiatives.
Yeah, but they're standards of tomorrow, or they're working towards a standard. Yeah.
So we don't need to wait until someone accepts advanced standards. Yeah. Let's work together. And that's the meaning that we want to pass, that we should, and hopefully, I think it's maybe the first time ever that all those people are going to be on the same room. So,
and that
again, IHE will innovate as we did, and we brought users and vendors 25 years ago together. We will do the same here, and use the European Health Data Space as the parrot to do that.
So what can I say other than thank you for spending some time discussing this enormous subject? And we could talk for the rest of the week around this. But I think this gave a sense of the scale of what is being attempted. And also, I think the scale of the response. And I think this is a really interesting space to watch, because we're going to be seeing an awful lot here, especially considering the European Health Data Space developments. So thank you, Alexander. And we meet in Helsinki to do some human interoperability now.
Exactly. I will be there.
And me too. Thank you.
Thank you as well.